Next, we have a roundtable case discussion of a case born at 27 weeks. The moderator for the session is Dr. Prakash Manikoth.
Dr. Prakash Manikoth, consultant neonatologist, Armed Force Hospital, Muscat, Oman. He is also a clinical lecturer in pediatrics and trainer in pediatrics and neonatology. He has published widely in the peer-reviewed journals and is a reviewer for international journals and McMaster online rating of evidence. His areas of academic interest include golden hour management, non-invasive ventilation, neonatal care in low-resource settings, and quality improvement initiatives. We kindly welcome you, sir, to the dais.
We humbly invite the delegates participating in the roundtable case discussion to occupy the dais. We welcome Dr. Manoj Malviya, Dr. Arun Nair, Professor Eilon Shany, Professor Shivani Shankar, Professor Leslie Lewis.
Shivani. You'll call him.
While they start, the idea of having case discussions in our conference was suggested, and when it was suggested in a different way, a live case to be presented by the person who actually experienced and then to be discussed. But then with the time, the pattern evolved. That was how we planned in 2019 when we designed the 2020 IAP Neocon. But within the next 2 years, it evolved. And then when we had more sessions being added, it had to be made to it. This is a case that has actually happened, but it is not being presented by the people who have actually had this baby. Over to you.
Yeah. Good evening to all of you. Greetings from Oman, where I worked for last 30 years. I compliment the organizers and the team Manoj for organizing such an amazing academic activity. And I thank him for giving me the privilege to moderate this session. I'm also privileged to moderate this session by a panel of experts from around the globe, starting with Prof. Leslie Lewis, who is the head of department at KMC Manipal, Dr. Eilon Shany from Israel, Manoj Malviya from Oman, Dr. Arun Nair from New Zealand, and Dr. Shivani Shankar from Paris. We expect Arun Nair to join shortly. Yeah, he's in front of me. Thank you, sir. I have no conflict of interest and nothing to disclose. My panelists have agreed for a very micro introduction. I'll take only 10 seconds. Dr. Arun Nair is currently working at as a neonatal pediatrician and consultant neonatologist at the Waikato Hospital, Hamilton, New Zealand. He's a senior clinical lecturer in pediatrics, College of Medicine, Auckland, and he has been a PA for many studies. With that, I'll go to the next person. Professor Eilon Shany is from Israel. He is a professor in pediatrics at the Ben Gurion University of Niger and head of the neonatal department in Soroka Medical Center, Israel. I like his comment, leave study and graduate in Israel. A so simple man, and his areas of interest, traveling and meeting people. Professor Leslie Lewis is the head of department at Kasuba Medical College, Manipal. I'm sure most of you are familiar with him. He has published extensively. He's a PA for many projects, and he has been a recipient of many awards also. And Dr. Manoj Malviya is currently a senior consultant in neonatology at the Kala Hospital. He was my colleague at Royal Hospital for over 10 years before he went to Canada and Australia. And he has again come back a second time. I think I'll skip mine. Dr. Shivani Shankar Aguilera, he is working as a senior consultant and ICO at Antonio Beckler Hospital, South Paris University, Clermont. She is a member of European Society of Pediatric and Neonatal Intensive Care, and she is an expert on lung ultrasound. I was fortunate to attend her lung ultrasound workshop today morning. Over the past 5 decades, neonatology is in a state of flux, and ranging from experience-based to evidence-based to finally precision medicine. But I still believe it's an art based on science, and that's why we have the expert panelists sitting here. Professor Leslie Lewis will start with managing the golden hour, and followed by Dr. Shivani, who will support the lung. Manoj will support the heart. Eilon will support the brain. And finally, Arun Nair will talk about feeding. Coming to the first one, I'll start with a case study. A 30-year-old woman at 27 weeks gestation is with a growth-restricted fetus of 24 weeks, is admitted in labor, received a dose of Dexa and Maxelf. On admission to the labor room, she is febrile. Her cervix is 3 centimeters dilated. Maxelf continued and second dose of Dexa given. Uterine contractions continued with the progressive cervical dilatation. NICU team is informed to prepare for imminent delivery. So, Professor Leslie, what antenatal counsel will you give to the patients, and how will you do a team briefing?
Yeah, here, as Professor Swarnarika Bhatt Madam has pointed out, the parents are important. And any antenatal counseling, parents is the key. Only thing is, some of us forgets the obstetrics colleagues. So we want to have obstetrics colleagues with us, along with the parents. And our concentration in India is to improve the outcome of 26 to 28 weeks gestation. So I will tell this is what is the outcome of the babies. These are the immediate outcomes. These are the problems are anticipated. ABC is the baby requiring a resuscitation, ventilation, surfactant maybe. And second thing is the complications which a baby could have, could be a necrotizing enterocolitis, a poor feeding, or chances of the intraventricular hemorrhage. And then the important fact is most of our parents are not able to afford the cost. For this baby, which might take at least 3 months of a hospital stay. Our discharge criteria is 1,700 grams, 35, 36 weeks completed. So our setup may be cost about 3 lakhs rupees, plus minus government insurance, private insurance, and short about the long-term outcome. And the obstetrics colleagues is to be there while I do the counseling. Most of the times we forget them. This is what I had to do. Team briefing, I will take the best team who could able to best persons who's expert in intubation. It's not the senior most, but he who has done a number of high-risk deliveries and intubation. Second person could be to take care of the cardiovascular support. Third person for medication and documentation. 4 people, 1 senior resident, 1 respiratory therapy facilities we have, and staff nurse. And I assign the role to them, and plus team briefing with the obstetrics team also, what to be done. And I will be taking the lead here.
Yeah, that's well said, Professor Leslie. Shall I just throw some questions to the audience? In this particular infant, 27 weeks with 24 weeks gestation, delayed cord clamping is indicated. I will ask the audience to raise their hands if it is true. Okay. Umbilical cord milking is indicated in the absence of delayed cord clamping. Please raise your hands if it is true. Nobody. Okay, great. Uterotonic is given soon after delivery before delayed cord clamping. Raise your hands if it is true. Nobody. Great. So, Professor Leslie, what is the current recommendation for delayed cord clamping in extreme preterm infants? Do you advise umbilical cord milking in extreme preterm? And what is the ideal time to administer a uterotonic, which is commonly pitocin?
Okay. What we have is presently 28 weekers and above, at least 30 seconds to 2 minutes of a delayed cord clamping if the baby is having good respiratory efforts. If there is no good respiratory efforts, and we can take a call there, resuscitating the baby with the intact cord and continuing. Delayed umbilical cord milking, we don't do routinely, and I'm sure there is no information or no evidence is available below 28 weeks of gestation to do the umbilical cord milking. So I won't consider umbilical cord milking.
When I talk, okay. Can you just cancel that echo from the panelist? So the last statement, the oxytocin.
Oxytocin, yes. Maybe after the umbilical cord. I think we should do is umbilical cord as cut. We should give the oxytocin and not before that.
Okay. So you can continue your.
Okay. See, this is I think this is the published data which is there. Why delayed cord clamping? Everyone now know about it, and I think it is a 5 minutes. The saturation is better when we have a delayed cord clamping of more than 30 seconds, maybe extended for a certain period of time. Whereas early cord clamping, the set targets of a saturation may not have reached. So that's the reason the best to have a delayed cord clamping, and it is practice.
Professor Leslie, is it feasible and appropriate to resuscitate with an intact cord?
Yes, we should do it, and we are doing it. I will be happy doing it for a 28-weeker onwards. We don't have much of exposure below 26 weeks onwards. And these are the two tables, the Mayo table, which is there on the left side, which is very cost effective, which can be just slide into the operating room where the operation is going on. And the baby can be taken over there and resuscitated on that table with the intact cord. The other one is expensive and we don't have it.
Can you discuss the concept and key elements of the golden hour and what preparations will you be required for delivery, and describe a sample golden hour protocol?
Yeah.
Briefly.
3 things I'll be concentrating. First is our temperature. And I put up here 26 to 28, even though where it is 24 to 26 degrees mentioned, because that is what is required. A pre-warm linen, rewarming surfaces, eliminating the drafts are required. And we use the warmer to resuscitate. We don't have a facility everywhere, the incubator to resuscitate. So that is what we are following. Directly put the baby into the polythene bag. And then the baby is vigorous, just put the TP's resuscitator with a PIP of around 15 to 16 and a PIP of around 6 and BFI of 21 to 30%. If the baby is non-vigorous, then maybe continue for about 5 to 10 to 15 seconds of TP's resuscitation, and then consider to the intubate. If the baby is already having a good respiratory support, continue on a CPAP, delivery room CPAP, around 5 to 6 centimeter of the support, pressure support, with a heated humidifier. I mean, the humidification and blenders required. And then we won't consider giving a surfactant in the delivery room. Possibly, I will ship the baby to the NICU and consider, based on the baby's condition, to give a surfactant. So this is immediately next is shifting the baby to NICU. So, and keeping the baby on a peripheral IV access or maybe umbilical IV access. So preferred fluid is around 10% dextrose, 80 to 100 ml per kilo for less than 1,000 grams. And this is babies under the warmer, around 4 to 6 milligrams per kilo per minute of a glucose. And that is the targets what I'm using. And my first glucose level in the baby should be around 50 and up. and then amino acid continuations, we will do it. So further continuing, the baby, we will avoid the hyperglycemia in this baby, and we continue the respiratory support as I mentioned. Since the baby is breathing well, possibly we'll continue the non-invasive support with a CPAP alone. Surfactant, it depends on the baby's condition. If the baby is not breathing and required to intubate, required more than 30% of oxygen, possibly I will consider surfactant.
Okay. What about sepsis? How do you proceed?
Yes, very important thing. I think mandatory to have a precautions, a strict asepsis, no routine use of antibiotics unless there is a strong indications are there, a maternal infection is there. Maybe I will consider first dose of ampicillin. In our setup, we consider ampicillin and aminoglycoside as a first level antibiotic. Otherwise, I won't do it. And basic labs in that first hour, I will do is glucose, WBC counts, culture, and maybe a capillary gas or a venous gas. To sum up till the slides come up, the first 1 hour. So
Professor Koldiwal, sorry to interrupt. Professor Koldiwal, are you there?
Yes, I'm here.
Hi. I'm so sorry since we waited for you and then we started the next session. So after this is over, shall we start immediately after this? Will it be too late for you?
No, it's okay. I thought this was my time.
All right. So maybe after half an hour, we can have your session. And it's that's okay with you?
Yeah, so did I read the time wrong?
No, yeah, because we waited for you for 10 minutes, then we started the next session.
4:45 p.m. EST to me was 21:45. So it was an hour late. So I apologize for that. I must have read the time wrong.
No, not an issue. I will have to stop this because people are watching. They will not be able to view the other one online. I do not have a separate link, so I'm interrupting them with sincere apologies to all those who are watching. Okay. Is it okay after this session is over? Immediately we'll call you if it is okay.
Yeah, sure, no problem. Yeah.
And then we will have to wind up the session at 6:20 Indian time because we have another online speaker, Professor Martin Kessler, immediately after that. So that will be another. We lost 10 minutes, so we will have to catch up with that. Anyway.
Okay.
Thank you. So I'll catch you in another maybe half an hour.
Half an hour. Okay. Thank you. I'll stay on.
Just tell you. Yeah, half an hour. Yeah.
Okay. I'll stay.
Please raise your hands if you say it is okay, or is it provide CPAP, or is it intubate and administer? Who will prefer option A? Please raise your hands. Who will prefer option B? Okay, that's the right answer. Dr. Shivani, can you tell us what is the ideal mode of respiratory support after birth? And what are the actual indications for intubation and surfactant administration?
Okay, so I had a couple of slides, but I think Dr. Leslie has covered it already. Just after birth, of course, CPAP is the preferred mode of respiration, prophylactic CPAP. We take a couple of seconds, every 30 seconds to evaluate and assess whether the baby is transitioning satisfactorily from the intrauterine to extrauterine life. Okay, so you take some time to see whether the transition is incomplete. Does the baby need some more time? Or is it completely failed or poor transition by assessing heart rate, work of breathing, and the tone of the baby, okay? So if the transition is incomplete or failed, you can, along with your positive pressure ventilation, give 5 inflation breaths, 2 to 3 seconds. And if the baby is still not breathing, you can ventilate the baby at 30 per minute, okay? So this is all to establish a satisfactory transition in a baby who has spontaneous breathing efforts. I'm showing these slides, these graphics from the European resuscitation recommendations, which came out in 2021 based on the ILCOR consensus of which Professor Davis was a part in 2020. So the idea is to reach 85% or more than 80% SpO2 by 5 minutes of life. Okay. Yeah.
Yeah.
So now we have our baby on CPAP, whose transition satisfactorily is vigorous, spontaneously breathing. We are in a catch-22 situation now, or, in a bit of a dilemma. We know that surfactant is more efficient when administered within the first 3 hours of life. However, most of our babies, when they are stable on CPAP and there's no sepsis or any other problem, they go on to increase their oxygen requirements after 3 hours of life. And for the moment, for lack of any other evaluating factor, for the moment, FiO2 requirement is the by default measurement which we take as CPAP failures. There are other things, but in the first few hours of life, that is the most commonly, even though it's very arbitrary and the level of evidence is very low, but more than 30% FiO2 is the currently agreed upon consensus to administer surfactant. So the dilemma we were facing was how to know which baby will need surfactant and probably give it in the 3-hour period if possible. So this is where the lung ultrasound comes in. We've been doing it for the last 8 years. We've talked a lot about limited and low resource settings. So this is a way to take what we have already even a step further. So this is a resource which is in every neonatal unit, an ultrasound machine where in addition to looking at other organs, you look at the lungs. And we've just defined a semi-quantitative lung ultrasound score whereby you score 6 areas of the lung. You give them a score from 0 to 3. So the maximum score a baby can have is 18, and the lowest score a baby can have is 0. 0 is like perfectly normal lungs. And with a cutoff score of 8 for babies less than 28 weeks, it has a 90% specificity and sensitivity to predict which babies will go on to receive, to increase their FiO2 requirements.
So can you describe the preferred ventilation strategies in the RDS?
Yeah, so it's a vast subject, difficult to say in just one slide. But there is one thing I would like to insist on, which is the period when you administer surfactant is when you administer surfactant and you, if you do it by Ensure or if you keep the baby intubated, that is the time when due to the surfactant, the compliance will increase dramatically. And so if you're on a purely pressure support ventilation, you risk causing a lot of volume trauma for the same amount of pressure. So this is the period where a volume controlled or volume guarantee is very important so that the baby auto-weans itself on the pressure. So a pressure support with volume guarantee, you can use an SIPPV with VG, which is a very protective mode. There are other, modes. I personally like high frequency in case babies need ventilation for a longer time. But there is one thing we have to know. We've talked about non-invasive ventilation. At every point of time when you see the baby, you need to ask, why is the baby still ventilated mechanically? And at any point of time, non-invasive ventilation is better than mechanical ventilation.
Yeah, in a few seconds, what about oxygenation targets for preterm infants?
Yeah, so in the Cochrane reviews and the NeoProm study, between the lower and higher oxygenation targets, there was no real significant impact on the composite death and major disability at 1.5 or 2 years of age. Okay, the only difference was in the lower SpO2 range, the rate of death and necrotizing enterocolitis was higher, and the rate of retinopathy was less. So the current practice or the current guidelines are to have a range, a wide enough range so the baby actually spends time in it and not keep decreasing and increasing oxygen, the oxygen delivered. So 90 to 95% with an alarm setting of 89 to 96%. And there is an argument, if you are in a center which has more ROP, you can probably adjust your FiO2, your SpO2 ranges within a couple of shortening or increment of the range.
Yeah, continuing on the case study, the caffeine is loaded at 1 hour while on CPAP gets caffeine loaded at 1 hour while on CPAP gets intubated because of increasing oxygen requirement. Receives surfactant, SIPP mode of ventilation, providing 6 ml per kg of tidal volume. And 2 hours after surfactant, the oxygen requirement comes down to 30%, but the ventilator settings remain the same with an expirated tidal volume now reading 8 ml per kg. And 4 hours after surfactant therapy, she requires still higher 70% FiO2 to maintain SpO2 of 94. She's tachypneic with severe subcostal recessions, decreased air entry of the left hemithorax. To the audience, which of the following is mostly likely diagnosis? Who will be saying option A, E? Anybody for option E? Okay, option A. Okay, that's a great majority. Okay, fine. So, Dr. Shivani, can you explain the role of lung ultrasound in the assessment of complications?
Yeah, sure. Lung ultrasound is a very non-invasive, zero-cost assessment that you can do and get an immediate answer. One of the studies our Italian counterparts did was to see how long it takes to diagnose a pneumothorax on chest x-rays or lung ultrasound, and the lung ultrasound delay was 4 to 5 minutes, whereas the chest x-ray, the best they could get was 20 minutes. So if you want to know whether it's a pneumothorax, it's the best way to see. I had a loop flowing somewhere. Can you show the loop? It's late. Okay. So the lung ultrasound is able to show effectively whether the lung pleura are sliding or they are separated. So this is a very easy skill to learn, to know whether there is pathological air between the two pleura, and you have very definite unambiguous images which can help us confirm our diagnosis. So as I said, lung ultrasound is an easy bedside tool. You can repeat it as many times as you want. Minimal discomfort to the baby, immediate answers, and the learning curve is quite steep, and it is very cost effective. So this is a quick show is that, on the left side of the image, you can see the lung pleura is moving. This is why the vertical lines seem to be moving a little bit. A is for air. So on the right side, you have A lines, but horizontal lines, which don't seem to be moving. So this is the point where you can see on the chest wall, on the parietal pleura, this is exactly the point where the two pleura separate. So there is absolutely no ambiguity about it.
Thank you for expert comments. Now I'll move on to Dr. Manoj, who supports the heart. The left pneumothorax, this baby had a left pneumothorax, gets drained with needle drainage, and on day 2 on SIPP mode of ventilation, the infant appears pale pink with a capillary refill time of 3 seconds, a blood pressure of 32/23, mean of 26, urine output of 1.2 ml per kg per hour, chest X-ray shows mild cardiomegaly, X-ray shows, echo shows 1 millimeter PDA with a bidirectional shunt and LV dysfunction. What is the next choice of treatment? Can you raise hands who will opt for option A? You saw the blood pressure, I'm sure. Who will opt for A? Who will opt for B? Who will opt for C, D? Anybody for A? Please raise your hands. Anybody for C? Okay, a few people are there. Okay, if you decide about ionotropes, what is the drug of choice for ionotropes? Option A, please raise your hands if you support. Option C, please raise your hands. Okay, right. So quite often we hear the registrar telling the BP is low, but the baby is well. What to do? So can you, Manoj, can you describe the approach to neonatal hypotension in a preterm infant and discuss the management of cardiovascular compromise in the same patient?
Hi.
So the blood pressure is commonly employed and one of the common surrogate marker used to assess the cardiovascular well-being of an infant. And whether the blood pressure is normal, then most likely the heart is working well. But I think there is a problem in this assumption. Mainly three. The first is that we don't have a robust definition of what constitute normal blood pressure. Because if you look at the common definition of hypotension is most of the people will use mean blood pressure less than gestational age. And there are not enough randomized control data validated this definition. I think the second issue is about blood pressure using as the only marker of cardiovascular well-being is its association with the organ perfusion. I think it is not correlated very well. Your blood pressure may be normal, but your organ perfusion might have been is compromised. The best example is sometimes the bleed. The blood pressure is a product of cardiac output and peripheral vascular resistance. So if you have got a bleed, the baby's body peripheral vascular resistance will go up and the blood pressure is maintained, but the organ perfusion will be compromised. If you will see normal blood pressure, but if you do an echo, SVC flow will be low. So I think that is another. And the third is the most important thing is the outcome. The outcome, particularly if you look at there is a paucity of randomized control trial, whether if you follow a dictum of permissive hypotension means you just observe and don't treat it, versus you treat a blood pressure based on just a number. There are not many data suggesting are available. Only observational studies are there, and they are contradictory. I think some studies have shown that if you treat hypotension, it is associated with IVH and increased mortality. At the same time, just recently, one study from France came that they just treated an isolated hypotension and the outcome was better. So I think the picture is not very clear.
But Manoj, can we discuss the management?
Yeah, so I think if simple thing, what I follow is if the baby is clinically stable, use all other parameters, that if the urine output is good, lactate is not high, CFT is normal, then I think approach of permissive hypotension might be acceptable, and there are studies to support that outcome is not bad. But if there is a systemic I think cardiovascular compromise, then you might have to use integrated approach, use use your biochemical parameters. If you have got a facility of echo, you can use echocardiography, and particularly if you have got a nurse to look for the organ perfusion, then you incorporate everything and then come to an conclusion. But I think most of the unit in NICU in India might not be having easily available echo. So I follow this simple principle of look at the systolic blood pressure, look at the diastolic blood pressure, and look at the mean. I think it's very simple. If you have got a low diastolic pressure, then mainly three major causes. One is warm shock and the PDA. I think the difference between warm shock and PDA is the pulse pressure will be widened, whereas in warm shock, the pulse pressure usually will be normal, because there will be some element of decrease in systolic pressure. If you have got a systolic is low, then most likely you have a problem with the contraction. So I think then there may be a septic shock, which is in severe cold shock, or there is a cardiogenic shock of any region, or sometimes PPHN. If there is a systolic and diastolic, both are low, then same PPHN as in the list, cardiogenic shock, or a PDA. I think treatment is if you have got a peripheral vasodilatation, diastolic is low, then most likely you will have to consider some sort of vasopressin, vasoactive substance like vasopressin or dopamine. But if you have got a problem with the contractility, then you can consider using dobutamine or epinephrine or norepinephrine. I think if you have got a sepsis as a cause of this one, then I would prefer norepinephrine.
I think this
It's a very complex topic and can be debated.
This our infant develops a hemodynamically significant PDA, but since the next session is going to be only on PDA, we will skip the slides. You agree with me?
Okay, so so PDA, there is a talk is there, so you don't want to.
If you want, maybe one slide, because next for 45 minutes.
Oh yeah, okay. So you can go ahead.
Yeah.
Yeah.
Now we will move on to Professor Arun Nair. Okay. This baby on day 1 receives oral colostrum and starter TPN. Trophic feeds 20 ml per kg with expressed breast milk. Enteral feeds reached 40 ml per kg on day 5, along with total parenteral nutrition. The following are contraindications for early enteral feeding: dysmotility, umbilical arterial catheter, hemodynamic. Who all will agree with this? Raise your hands. None. I think that's good. Dr. Arun, can you explain the barriers and strategies for initiating and advancing early enteral live feeding in extreme premature infants?
Okay. At the outset, I want to thank the organizers for having invited me and the rest of my colleagues here. We didn't have time to talk about it, but yes, thank you very much for Manoj and colleagues. The question here is the barriers to initiating enteral feeding in extreme preterm babies. I have outlined here 3 major factors that can impact the enteral feeding. And the first and foremost would be non-availability of the mother's own milk. This is one baby in which I would be very wary of using a formula. So I'm really interested in mother's own milk here, and I don't have time to really go through about how we can go about it. But I have given you a reference here from our own, in Hyderabad, Murki and his colleagues. They have dealt with this in a very recent article. And I think I will refer you to how we can, overcome those sort of things. The second and the most important thing that I have found is lack of knowledge and understanding among the healthcare workers. I'm not blaming anybody here, but the problem is that many of our colleagues are still not on board with this understanding that the intestines of these babies were not being fed is going to stunt. The villi are going to atrophy if you have not started feeds as early as possible. You have to remember that fetuses, when they are in the womb, are constantly being fed by the amniotic fluid and other substances, and the intestines are working. And if you keep the baby's intestines not working or not giving enough substrate, there is major harm that can happen. And then of course, there are many medical and surgical problems. This is a paper by Kuhn and al., which was published recently and was forwarded to me by Prakash. And this illustrates very clearly as to how any of these barriers can be overcome. In fact, none of those are really barriers if you really understand. This is where I said, understanding is the most important thing. I don't want to spend more time talking about this, but none of these things should be considered as a real barrier.
Can you describe a sample feeding protocol for the benefit of the participants?
Sure. There is enough data now in literature which says that a standardized feeding protocol is the most effective way of really giving nutrition as well as preventing complications as a result of being born very premature baby. Here is an outline of what one of the authors have put in. We more or less follow the same sort of a protocol. Again, have a standardized feeding protocol in your unit and stick to it. That's my recommendation here.
Okay. So what is neonatal refeeding syndrome?
Good. So this is a very new concept. I think this is from in a work that we are doing at the Liggins Institute, where I'm a part of the team. We have been doing early aggressive nutrition and newborn babies. That's been the theme for the last maybe a decade and a half, that we have to be giving more proteins, we have to give more calories and those sort of things. And what we have found is the similar sort of problems that we used to see when we were giving, nutrition to the malnourished babies or malnourished infants in our setting. should not be very, most of the Indian crowd should be familiar with what we used to deal with. We are finding that these sort of things are coming up, with early and aggressive nutritional support. Be wary of that, because we have developed a sort of a scheme to tell you that refeeding syndromes, as is defined here, with the serum phosphate being low and the total calcium going up, is associated with increased morbidity and mortality. And it's been linked to, this is linked to high amount of IV proteins that are given. And this is part and parcel of a study that we were involved in called the PROVIDE study, where we were giving extra proteins to the babies as a strategy to see, if it improves the neurodevelopmental outcome, that is our primary outcome. But then we have found in a secondary analysis that we have done recently that some of these babies, especially the ones who are growth restricted, they are the malnourished babies coming from the womb. You need to be aware of this sort of problems that can come. And you can see in this cartoon here how it can impact on almost every morbidity that we talk about in a very preterm baby.
Day 6, this baby passes the first meconium, and we noticed increase in WBC count, increase in serum alkaline phosphatase, increase in blood sugar and metabolic acidosis. The antibiotics are upgraded to tazocin and vancomycin or aseptic workup. And day 7, there is a mild distension of the abdomen with no tenderness. Abdominal X-ray reveals pneumoperitoneum. So the most likely diagnosis, who will, please raise your hands if it is A. Please raise your hands if it is B. Please raise your hands if it is, B, I have repeated again. What I meant was C, and the last is D. Who will opt for D? Yeah, majority is opting for D. Who is opting for spontaneous intestinal perforation? A small number. So the abdominal X-ray reveals pneumoperitoneum. Laparotomy reveals spontaneous intestinal perforation. Undergoes resection, colostomy, end-to-end anastomosis after 2 months. So Dr. Arun, how can we differentiate SIP from neck in a preterm infant? And can you just briefly outline methods of prevention of neck?
It's going to be pretty difficult because, if you look at it, this risk factors for both are almost the same. Very low birth weight babies who are, growth restricted and so on and so forth. The tools will be, as I have mentioned here in the slide, as clinical, laboratory, radiological, and finally exploratory laparotomy. More often than not, you would end up doing an exploratory laparotomy for these sort of babies. We can't be 100% sure. And of course, at the end of the day, there is a histology to go by. And as I have mentioned here, between spontaneous intestinal perforation and NEC, one of the clinical findings that I often use is a baby who's not looking that sick. There are no much inflammatory markers around to show that there's an inflammation going on. And it's something that has happened very early in the course of the child's life. Often we have NEC coming towards the end of the second week or so, or 10 days or so. And if it is happening much earlier than that, it goes in favor of SIP. And of course, when you do a laparotomy, you will be able to see that often in an NEC, there may be multiple perforations, large segments of intestines are involved, and then inflammation is obvious to the surgeon. And when you send for analysis or, of the tissue, you will see that already changes that I have mentioned, like NEC would be obvious and NEC, but it won't be. So it's not that easy, but there are some clinical markers that you can use.
Okay. This is an actual patient in our unit, the particular X-ray which I showed. Let us go to the next one. And if one slide about prevention, you have time or?
Yeah, I can quickly say if you allow me. Some of you may have listened to my talk about evidence-based practice using bundles of care. In fact, there are lots of evidences for prevention of NEC now available to us. When you put them all together into a bundle, as you can see here, use of human milk, which I have already talked about, or immune therapy, it's a big name used for just using your fresh human milk. Mother's own milk for mouth care has got some immune benefits. Probiotics very early, and standardized feeding protocol, I have already talked. Antibiotic stewardship, we have to be very careful. And I've seen with quite distress that they use a lot of antibiotics and resistance and other stuff is coming on. So being very careful about how we use antibiotics, optimizing intestinal perfusion, which our speakers have already talked about, and prevention of anemia. There always used to be this issue whether blood transfusion causes anemia. I think that's no more an issue. We know for certain it is not the blood transfusion, but it's the anemia and the reperfusion injury that can happen after you start giving blood. That causes an increase. So there is an anemia, get on with it early and try to avoid it. That would be my suggestion. And this is a bundle that you can put across in your setting.
Yeah, thank you, Dr. Anil. Arun Nair, time to move over to the brain. I invite Professor Eilon Shany. Can we protect the brains of these preterms? Do you think it's possible?
Well, first, I would like to thank you for having me here and thanking Dr. Manoj. It's really a pleasure to be here between you. And I think that the panelists actually did the work for me because everything that you talked about it's about protecting the brain. But if we look at a premature baby, and a premature baby like the one that you described is definitely a very sick baby. But he's not only a sick baby, he was sick before he was born. It was a sick fetus because we already know, if you look at the placenta, and the placenta is a part of the fetus, the placenta is also sick. And it disrupts a lot of processes, and it also affects the brain. So when we look at the brain, and we know, most of you, all of you probably know that about the germinal matrix, that these are neural cells that are around the ventricles. But can you go to the next slide, please? These cells, we know them not only because they are affected by IVH, but they are also the basic of all our neurons and glia that eventually will populate our brain. So the real question eventually is, in this sick baby, can we change something? Can we change the trajectory? Can we heal the brain that is already affected? Or can we promote healing processes and stop any untoward processes toward the brain? The best would be a magic bullet, to have the drug that will stop everything. And erythropoietin was suggested drug or a silver bullet, but it didn't work. In this recent paper, 1,000 babies were treated, half of them were treated with erythropoietin and half were not treated with erythropoietin, and it didn't work. So we had to find other strategies. And please continue. Next slide.
Can you outline a neuroprotection care bundle for preterm infants, which is getting more popular these days?
Exactly. So if you can go on to the next slide. So we are talking about nowadays about protocols and bundles, because we don't have this silver bullet, and we have to go and see what is done in other units and how come. We know that some units have got babies that fare better, and some of them they fare worse. So by going to each of these units and looking where the outcome is better, we're able to come up with bundles. And most of the bundles, and in the next two slides I'll show it also, we're talking about the same things. If we're talking about the golden hour, we're talking about birth in a referral center, we're talking about giving steroids before birth, gentle handling, delayed cord clamping, respiratory support, which is gentle, either CPAP or volume targeted, cardiovascular support, and treating infection. And treating infection is not only, we know that the infections also affect the brain, because free radicals, they are, when there is an infection, there is a lot of free radicals around, and they arrive to the brain and they affect the brain. And this is one bundle in also in a recent paper, and you see that the same ideas are in most of the bundles, and I would add at least here the family involvement, which is extremely important. And we heard before, I mean, family involvement is not only the mother and the father. And we have to know that in many societies, these parents, they are very young and they have their parents that are also part of decision making, and are also counseling, and they ask around, and we have to get them to support the baby and to support the families, which is eventually is very important for the baby. And we want to be the parents part of the team that treat the baby. It's I cannot really emphasize how important it is to have parents near the babies. And I don't know, we have a personal experience of babies that fare much better when they have the mother that is continuously near them. Can we go to the next slide?
Can I throw some questions at the audience?
Sure.
Probably this is the last one. The sensory system of the fetus and infant develops in a sequential order, and the following statement is true. Vision develops earlier than sound. Option A, anybody supports that? Option B, vision develops earlier than smell. Please raise your hands if it is true. There are a few. And then option C, touch is the earliest sensation to develop. I think most of you got it right. So can you describe developmentally support care and neuroprotective core measures?
So probably you all know this cartoon of the lotus, and again it's talking about the same basics. But what I would like to stress here is and when you talked about the senses, it's the importance of letting the babies rest. And we all know the nurse that come at 4 o'clock in the morning to the internal ward and lights the light up and say, "Good morning, sir, how are you today?" and stick the temperature probe into you and give you the medications. And this is not healing. This is not a way that you can help people to heal. And it's the same for the babies. If you come every half an hour, you open the doors of the incubator and you say to the baby, "Hello, I'm here, I need to prick you, I need to take a blood sample. Well, I just forgot to take a blood sample half an hour ago, I'm going to take it again. And I just want to do an ultrasound scan, I just want to do an echocardiogram." And it's a never-ending disturbance of the baby. This is not promoting health to the baby, and it makes sense even if we don't know how much it really affects the baby. Do we know that from the experience that this baby, they fare much less? Now I would like to go to the last slide, I think, after this. And we have to remember that when the babies are getting out of the NICU, they're still ex-premature babies, and the families have to be part of the process. We know very well that when ex-preemies or every child is growing in a family that support the children, they fare much better. And this is important, not the less for the ex-premature babies. And we have to remember at least a quarter of these ex-premature babies, they have problems, either cognitive or neurological. And the best way, we have to remember that the process of healing of the brain, the process of plasticity, it continues throughout life. It doesn't end when we're born, doesn't end when we get out of the NICU, it doesn't end when we get out of school.
We have just finished right dot on time, but I'll take one last summary slide. The early life of an extremely premature infant is a critical period of transition requiring adaptation of multiple organs and systems. We heard from the experts. And whatever we do, medical interventions can have significant implications on immediate survival and long-term comorbidities. The mantra for an extreme premature infant must not be simply survival, it should be intact survival. With that, I end my, and before I conclude, let me quote the late William Silverman. "We cannot always make our patients better, but we can always make them worse." Thank you, my dear panelists.
I just have a small comment for that. Exactly something we say on our unit is patients are not doing well because of us. They are doing well despite us.
Okay, right.
Yeah.
So thank you, dear panelists, for keeping on time and active participation from the audience. Once again, thank you all. We are exceeded only by 8 seconds. I think next speaker is waiting online. Thank you again, once again.
We would like to thank all the delegates for your valuable inputs to this case discussion.